Did you know that a brachycephalic dog with BOAS has a 433% higher anesthetic risk than a dog with a nose? Let me rephrase that. That Frenchie that you're spaying later this week, she's more than 4 times more likely to die on her surgery day than any of your other patients. Have I got your attention? The reality is that thanks to the rising popularity of mainly the French Bulldog, you're probably doing GAs in these sorts of patients all the time. So how do we reduce that risk? How do we give your adrenals a bit of a break on the days that you have to anesthetize an anxious, chunky Frenchie, or even more so if you are part of a team that does airway surgery in brachy patients? Dr. Abbie Tipler is a surgeon who does a lot of surgery on squishy-faced dogs. At their brachycephalic care unit in Brisbane, they've polished the brachycephalic anaesthetic down to a fine art. And in this episode, she shares all the gold. From the days leading up to the anaesthetic to selecting the safest mix of drugs and making sure your patient wakes up calmly and well-oxygenated on the day of surgery. This episode is the ultimate masterclass in brachycephalic anaesthesia, which is why I wanted to share it with you. This episode is one of more than 600 episodes from our subscriber-only clinical podcasts. If you like this style of learning, where I dig for all of the pro tips and the updates from some of the best specialists in the world, then you will love our clinical feed. Go and check it out at thevetwell.com. Just click on the clinical content button. Our subscribers also get detailed show notes for each episode to use as a reference. I'm happy to share the show notes for this episode with you, including Dr. Abbie's pre-op brachycephalic history template. I've put a show notes link in the show description for you, wherever you're listening right now. Tap on that and we will get those notes to you. Okay, here is Dr. Abbie Tipler with a plan for safer brachycephalic anesthetics. Enjoy. So, how I'd like to approach this episode, it's from the perspective of a brachycephalic comes into my surgery and potentially GP, because we see them all the time, and it's going to come in for a spay or a dental or a lump removal or something I need to do to it and knock it out for. And I'm aware that they are, well, I'd like to know, are they different? Do we need to treat them differently? Do we need to do different things? And I know as the maker of the podcast, throughout the years, every now and again, we'll tackle a topic and the brackies will come up as a caveat or as a special case scenario. So the ECC guys will talk about prokinetics and there's all these little things. And what I'd like today is to put all those little things in one box to say, here's a good plan to get your brachy through their hospital visit procedure, anesthetic, and out the door with minimal chance of a disaster.
Yeah, absolutely. And I think, to answer that, are they different? Well, yes, they certainly are very different. And we know that they have about a 1.5 times higher likelihood of having an intraoperative complication and about 4 times more likely to have a postoperative complication. So they are different, and there are some special considerations when it comes to managing those cases. And that really does start with taking a history. So that's definitely a place that we can start in terms of setting ourselves up for success.
Okay, so should we start with the history? What do I need to know in my history other than your squishy face?
Yeah, okay. So my history with these brachycephalic patients tends to be very structured. And there's typically sort of 3 different things that I really want to know about this patient that comes to see me. So the first thing, obviously is how are they managing in terms of their airways? Now, one of the things actually that I'll touch on is that brachycephalic owners, as we know, they think that all of the signs that they are seeing in their dog are normal or normal for the breed. And often they've become very habituated to all sorts of abnormal behaviours, but they think that they are normal. However, the other thing that I've noticed is that they don't tend to lie. They don't sort of say, if you say, does he snore? They don't say no. They say, oh, yes, no, he definitely snores. And, I don't really take him out for walks because he can't manage. And they sort of say this like it's completely normal, but don't make things up. So you can actually get a really, really good idea of how the dog is coping just by asking the right questions. And I'll share my history taking template with you for the listeners as well. But essentially, I'll ask about how much exercise the dog can tolerate, and I'll specifically ask them the difference between a hot day and a cool day. I'll ask them if they go out for that walk, how long will it take them to recover? So what I'm wanting to see is a dog that can happily exercise for half an hour or so and can come back and doesn't appear like it's about to sort of, get itself into trouble. So if they're saying, 5 or 10 minutes and then we have to turn back or take a break, or that's a little bit of a red flag for there being a problem with the airway. Mm-hmm. I ask them about airway noise. Do they have noise without exercise, with exercise? Obviously, do they snore? And then I move to, do they notice with exercise or without exercise, potentially, do they change colour at all? And obviously this is a bit of a subjective thing, but if you don't ask the question, you're not going to get an answer. And then, have there ever been any episodes of collapse or the gums being bluish in colour? And usually I know the answer to that based on whether or not they can tolerate exercise, because usually if they say, he can run around in the dog park for a couple of hours with no troubles, then it's unlikely that they're going to have too many episodes of collapse.
So you're not just assuming because you're brachycephalic, I'm going all in on the brachycephalic protocol. You are still trying to stratify risk based on this particular dog's presentation based on what the client tells you.
Yeah, exactly. So, and the reason why I'm trying to get a really good assessment of this patient is for a couple of different reasons, which I'll actually get to. So airway, I guess, is step number one. Now, the second group of questions that I'm asking about is in regards to the gastrointestinal system. So I'm not sure if you've heard of the term aerodigestive disease, but I really like that term because it really links the two together. So we know that brachycephalic dogs are very, very prone to all sorts of gastrointestinal problems. They have a sort of a floppy esophagus typically with poor motility. They often have a larger esophageal hiatus, especially French Bulldogs, and this can lead to hiatal hernia, which is where that gastroesophageal junction can sort of slide in and out of the chest. And of course, this all increases their propensity to regurgitate or, in some cases, vomit. Mm-hmm. And the reason why it's often linked to the airways is that they may have these underlying primary gastrointestinal abnormalities, but then if they also have increased upper airway pressures, then that subsequently leads to a decrease in intrathoracic pressure, and then that kind of sucks everything cranial in terms of the ingested contents that might be kind of sloughing around in their esophagus or stomach. So it's really important to ascertain how the dog is doing in terms of its gastrointestinal system. Yeah. And I'll explain why in a second.
So we want to find out about your respiratory tract and we want to find out about your GI tract. And the two are kind of linked as well, as you said.
Yes, and so the two are linked. So then I'm asking questions about, is the dog regurgitating? And I'm also looking for signs of silent reflux as well. So that's often where they'll sort of be running around and they'll start to kind of make that hacking sound, or there might be a lot of licking their lips, extending out their necks is another one. So there's a few signs that they might be silently refluxing as well. Sometimes waking up suddenly from sleep is another sign that they might have some silent regurg. And then I also ask about swallowing as well. And this just adds to that overall picture in terms of severity of the obstructive airway disease. So often you'll find that they salivate a lot because they can't swallow and exercise at the same time. And sometimes you'll find that they have difficulty swallowing and eating as well. So I'm getting a bit of a gauge on whether or not that's an issue. And then finally, I'm asking about sleep. So I just like to have a bit of an idea. Do they wake up suddenly? Do they sleep a lot during the day? And that's to give me a bit of an assessment of how well they can actually breathe through their nose and whether or not they've got signs of sleep apnea.
Well, little things they do have issues, don't they? They're problem children.
Yes, so they're problem children, but I think having a bit of an understanding of how severely affected the patient is in terms of especially their airways and their gastrointestinal disease, can help set you up for potentially making some changes.
Okay.
Pre the dog coming in, and maybe potentially on the day as well. Another important thing that I will add in here is I like to get an idea of how anxious the dog is away from the owner. So if they say to me, oh, look, he's never left my side, and when I go out for half an hour, he becomes very anxious and I come back and he's in a real state with his breathing, then that's also a very important thing to know because, well, for a start, brachycephalics with high levels of anxiety, that can be a risk factor for complications. Mm-hmm. But secondly, that's exactly what I'm planning on doing is taking this dog away from the owner. Yep. And, am I in a position where potentially I don't need to do that? Can the owner be present for part of it? And I'll get to that as well. So what are my goals in terms of asking all these questions? And it's twofold. So the first is to get a little bit of an idea of how risky the, whatever procedure that I'm planning on performing is going to be. And the second is, well, are there things that I can change in terms of my protocols to reduce the risk of complications? And for the situation where the surgery doesn't have to be performed on the same day, can I pre-treat the patient to get it into a better state before carrying out my planned procedure? So obviously if it's a fracture repair or it's got a large sort of wound or something, then you may not have the luxury of being able to pre-treat it. Yeah. But if it's a spay or a dental or some other elective procedure, and you know that it has severe frequent regurgitation or severe brachycephalic obstructive airway disease or a combination of the two, then this may change decision-making around the case. Yep.
So, Abbie, this history, are you sending it to your clients beforehand? If you can, if it's a planned surgery, or are they doing this at home, or is this you chatting to them in the consult room?
Yeah, no, absolutely. I'm chatting to them within the consult room. I don't really find personally that questionnaires are as beneficial. I find that often the way that they deliver the information gives me a really good sense of severity. So, a lot of these things that I'm asking them are sort of semi-subjective. So I really want to see how the owner's asking the question and also, do I need to probe them for a little bit more information? So it's definitely a face-to-face. And it does take, 10, 15 minutes, of course, to go through these questions. But I think it's really important for these sort of higher risk patients. And we know they're at a higher risk. So there's a couple of things that we know are potentially risk factors for brachycephalics needing surgery. So one of those is if they require oxygenated admission. So it's a bit of an obvious one. But, an anaesthetic is going to make that dog potentially worse. And so if it's requiring oxygen, even if it has really other really severe signs of brachycephalic obstructive airway disease and you're planning on performing a dental, could that dog benefit from airway surgery first? Yeah. If it's very anxious, that can be an additional risk factor. In terms of, well, what do I do for anxious dogs? Well, there's a bunch of things. And in fact, we might talk about that in a separate little section because I think that's probably one of the most important things with treating these brachycephalic patients is to reduce their levels of anxiety.
And a lot of them are anxious, aren't they? Certainly in my experience, they seem to be little stress heads.
Yeah, they are. And I think, maybe it's that there's a certain type of owner perhaps that chooses these breeds and often they are very, very attached to the dog and the dog's very attached to the owner. So they do tend to be quite anxious. And there's also a thought as well that if they're suffering from brachycephalic obstructive airway syndrome, that can actually increase their levels of anxiety as well. So that's a very, very important consideration. And then a dog that's frequently regurgitating, that is certainly a risk factor. And so we want to be looking at ways that we can treat that patient prior to surgery.
Okay. So your risk breeds are can't breathe, I'm a puker, I'm a stress head. Those are the ones that you've got to watch out for.
Yeah, that's basically it. Yeah. And there's a few others that pertain specifically to airway surgery, but we're talking about brachycephalic patients in general, not specifically airway surgery. So which patients are going to benefit from some sort of pre-treatment. Okay. So the first ones are the ones that are the frequent regurgitators. And typically I will try to get that under control as best I can prior to whatever the procedure is that I'm performing, but especially if that's airway surgery. And one other thing that I will note is because the gastrointestinal signs are so intimately related to the airway signs, I know often with my airway cases that until I address that airway, I'm not going to have any hope in resolving their gastrointestinal signs. So I'm not delaying it for too long, but I'm often treating with something like a omeprazole at around sort of a mg per kg BID for a few days, or there's actually a new long-acting omeprazole that can be compounded from bova, which can also be quite useful, and I think probably decreases the vomiting that I've seen, which sometimes you will see with omeprazole. And if they vomit with omeprazole, which is obviously different to regurgitation, but if they vomit with omeprazole, I do get them to stop.
Okay. So how long is long-acting? Do you know? The compounded one?
So the long-acting lasts for 5 to 7 days. So it can be very useful. If I'm seeing the patient at the right interval before the airway surgery, then I'll consider the long-acting. But, of course, it relies on seeing them 5 days before or whatever to be able to get that in. So occasionally, if they are very severe cases, I'll also add in some metoclopramide at around half a mg per kg as well, BID. And I'll give you all of these doses as well.
Thanks.
The other thing that I find can sometimes help is to get them onto a low-fat gastrointestinal diet. And I think how this helps is that when it's lower in fat, it passes out of the stomach sooner, so potentially can help a little bit with the regurgitation, and that can sometimes help them a little bit as well. So if I can get their regurgitation somewhat under control before surgery, then obviously that's better, because what we're trying to really avoid, and I'll talk more on this, but we're really trying to avoid a lot of regurgitation in hospital, which of course has the risk for aspiration pneumonia.
Okay.
Just as another small thing, if I've got a frequent regurgitator, I will often get the owner to give a very small meal around 3 to 6 hours before I plan on anaesthetizing them. There's a little bit of research around this. It doesn't specifically pertain to brachycephalic dogs, but I think certainly in the human world as well, they've moved away from these long periods of fasting. So especially if the owner says to me he regurgitates when he's hungry, that would be the one where I'd get them to make that extra effort to feed maybe just a tablespoon of food a couple of hours before they set off for the surgery.
Okay.
I try to avoid really long periods of fasting with my brachycephalic patients. And also on that note, I will often, and not just for that reason, but I'll often try to perform any brachycephalic surgeries early on in the day so that A, they're fasted for a lesser period of time, but then B, obviously if there's problems in recovery, we're not dealing with staff handovers and whatnot into the evening. So the second thing that I will always treat for if there's indications in the history, and often I'll combine this with some thoracic radiographs, but if there's any evidence of aspiration pneumonia, then this really should be pre-treated before it's anaesthetized. It can be very risky anaesthetizing a patient with aspiration pneumonia, and if there is any chance that they can be treated in advance, then obviously that's going to be highly preferable. And obviously I've got the luxury of liaising with our internal medicine team about the treatment and helping me interpret the radiographs, etc.
So are you basing that, Abbie, on history of how much are you regurgitating, or is it based on a history, like a physical examination of your chest sounds clear, or are you X-raying them if they're heavy pukers, or like how are you deciding? Do you maybe have pneumonia?
Yeah, so usually they're also coughing. So, and it's a little bit of a different, I tend to find it's a little bit of a different sound to that hacking that's more of a throat irritation. So it's more of a cough. Sometimes they're unwell, but certainly not always. I find that there's a lot of brachycephalics that can have this chronic low-grade aspiration, and they're not necessarily, sick with a fever.
Yep.
Sometimes you can also run a CRP, C-reactive protein.
I was going to ask you that.
It's very non-specific, but it can give you some indications that there's some inflammation going on, because you won't always detect aspiration on radiographs. And the other thing is you always have to assess the risk of taking those radiographs as well. So I did recently have a patient that was a frequent regurgitator, and it had had a previous history of aspiration. It was now coughing. I had airway surgery planned. This dog was going to continue to get bouts of aspiration pneumonia without the airway surgery, so it had to be performed. And it was a very, very stressed, anxious dog. So I actually opted to pre-treat with antibiotics. I don't usually do this. Obviously, we need to be very careful with our use of antibiotics, but I did decide to pre-treat this dog with antibiotics without confirmed evidence of aspiration. So just based on its history of previous episodes of aspiration, the fact that it was a frequent regurgitator, and the fact that it was now coughing.
You're right, because it does sound, I didn't think about that, but x-rays, you want to check if it's safe to sedate. So you have to sedate it to take x-rays to see if it's safe to sedate. I see what you mean. Or you've got to pin it down and stress it out, and then it regurgitates and aspirates while you're taking x-rays.
That's exactly it. That is exactly it. So, in those situations, the alternatives are potentially you could give it something that's fairly safe, like trazodone, and maybe, a little bit of a reversible sedative like medetomidine. That's going to be pretty safe to take some radiographs. But the question is, do you go to that extra effort? And of course, most of the time you do, because we want to have a really good understanding of what's going on. But potentially, if everything's screaming aspiration pneumonia, then you could just treat.
Okay.
So aspiration is another one, obviously, that I pre-treat. The third thing that I think is really, really important is if it's a highly anxious dog, I will send the owners home with trazodone to give on the morning of surgery. And I find that that's really, really helpful. I usually pick a dose of somewhere between 5 and 10 mg per kg. Sometimes I'll get the owner to test it in advance just to see the level of sedation if I'm really, really worried about the anxiety levels of the dog. But I think it's really important for these patients.
And can I just say, it's already a lot before you've even done anything. Are clients open to this, or are they like, what? You've spent all my money and you haven't even touched my, we don't even add surgery. Do people get it?
I mean, I think, I absolutely think they get it. I mean, they're already coming in for the consult anyway. So the only extra additional cost, may be a trazodone or an omeprazole. I don't think that's ever factored in. I mean, obviously, I'm lucky in that a lot of the pet owners that come to me are not financially constrained. Yep. However, I think most of the time, if there's something that can potentially reduce the risk of a complication, owners are pretty happy to take that up. And I mean, also remembering that complications tend to be very, very expensive. So if we can avoid them in any way, then obviously that's ideal.
I'm trying to make that practical, because you're right. It's definitely, you have a biased case selection. They're going to be the sicker ones. The dog that's going to come in for its routine procedure with me is not necessarily going to be that bad. But I like this conversation to say, before you book in that dental, do have this conversation. Again, identify the risk ones where you may want to do these things, and explain to the owner, I don't want to kill your dog with the dental, so here's why we're going to do a couple of extra things beforehand.
Yeah, exactly. And you'll be pleased to know as well that there's a few things coming up which are completely free of charge that you can do to reduce the risk. So,
quick interruption to give you an update about Vets on Tour, the epic conference company that I joined earlier this year. Our Japan Ski conference is about 75% sold out. So if you were thinking of joining us in the snow for our ECC/surgery/imaging focused CPD content, get onto it. That is from the 24th of February to the 1st of March 2026 in Nozawa Onsen. And if snow is not your thing and you're more of a warm water, cocktails by the pool and epic surf person, then maybe you should check out our Maldives conference. Actually, I was telling a French-speaking person about it the other day, and she nearly had a heart attack when I called it Maldives, like the Australians do. Our Maldives conference, We just released the final academic program on the website at vetsontour.com this week. But to give you a sneak peek, here's what the average day will look like. Sunrise surf, some medicine, breakfast, surf or dive or fish, some surgery, some medicine, dinner, cocktails, bed. It's a tough life, but somebody's got to do it. We'd love to see you there. Go and check it out at vetsontour.com. Okay, back to Dr. Abbie.
The first thing is stress management. So anything that we can do to reduce the stress of that patient, we want to do. And look, all hospitals don't necessarily have the luxury of having a separate room for the brachycephalics or area, but if you do have that luxury of keeping it in a slightly quieter area of the hospital or a slightly darker area of the hospital, or sometimes they like having some music playing from an iPad or something. So, and that's also something that the owners may be able to give you a few clues on. So, if they don't like their feet being touched, don't touch their feet. If there's a toy that they specifically like or a blanket, get the owners to bring that in with the patient. So anything that we can do to reduce the stress of these patients, we want to do. The other thing is if we can pre-medicate them fairly early. So ideally, we don't want them sitting in the hospital all day, getting very stressed. They may have trazodone on board. If they don't have trazodone on board, and as soon as you admit them to the hospital, they seem very anxious, then often those patients, we will administer some trazodone in hospital, and then we get them early pre-medication and also early pain relief. So if there's any indication that they are in pain, then we want to treat that quickly as well. That's going to reduce their stress levels, but also potentially their panting and oxygen requirements as well.
Can I ask there with the pre-med, are we going to come to which drugs you're using for your anesthetic, or is this a good place
Absolutely.
to ask what are your pre-meds,
Yep.
or am I jumping ahead?
Yeah, no, that's a good place to ask. So I like dexmedetomidine or medetomidine. Both of them are reversible. They are quick acting. They're very reliable in terms of what sedation we can typically expect. They're dose dependent, so a higher dose gives a higher level of sedation, and we don't get any laryngeal dysfunction. Okay. So it's a fairly safe drug, and we probably use it at much lower doses than, certainly what I used to use in general practice. I'm horrified to think what doses I used to use now.
Back when medetomidine first came out, we gave those big doses.
The chart, yeah. I mean, you went off the chart, so you felt like you were doing the right thing. And I mean, gosh, it certainly sedated them, that's for sure. But, we're using tiny doses and doses that I feel probably take the edge off, enough to get a catheter in, but aren't knocking them flat like they used to. So for dexmedetomidine, the dose we use is somewhere between 2 and 4 mics per kilo. Okay. And then we're also giving an opioid in most instances. And if it's a short procedure like radiographs and it's not painful, or potentially even a dental scale and polish, you could use butorphanol. So butorphanol, as we know, it's a little bit shorter acting, but it does have a slightly better sedating effect. So also really good for those brackies that come in and they are heat stressed and in trouble. Okay. But most of the time for my procedures, I'm using methadone, and I'm using that at a dose of 0.3 mg per kg. But certainly I'll give you a accompanying notes with all of these doses.
I just want to double check. So that 2 to 4 mics per kilogram, is that the dexmedetomidine?
That's dexmedetomidine. So medetomidine is double the dose. It's double the strength, but it's the same volume in mils.
Okay.
Yeah. So you do have to be a little bit careful that, if you have dexmedetomidine and medetomidine at the same practice, that, you're just double checking your doses.
Okay. All right.
You might say, well, why are we trying to reduce anxiety? And maybe I'll just talk a little bit about what my goals are for brachycephalic patients on the day of a procedure. And it can be broken down into reducing stress, reducing regurgitation, and those two are very, very intertwined because they regurgitate when they're stressed. And if they regurgitate, they get more stressed. And then the final thing is just being very, very careful with drug choice. So I often kind of joke that it's the only time a surgeon has to worry about pharmacology is with these brachycephalics. If any patient's going to have some sort of a drug reaction, in my experience, it tends to be a brachycephalic dog. So I often won't give them drugs unless there's a clear indication for it. So I steer away from let's just give them a bit of extra opioid just in case they're painful. I'm really looking to see and ascertain, how painful is the procedure. Does it need a top-up of the opioid? I'm not necessarily just giving it as a standard every 4 hours or whatever it is that I usually might do with another patient.
So it's very much a fine balance of saying, make sure you give enough drugs because you don't want them sitting stressing and regurging, but also just enough Goldilocks drugs, not any more than you need.
Yeah, well, this is exactly it. We know that opioids, for example, can cause cardiovascular depression. There was actually one study which found that lots of opioid top-ups increased the risk of the procedure. But then on the flip side, we really want to avoid pain as well, because pain can lead to them becoming very stressed and tachypnea, and then they can regurgitate. So it is a fine balance. And again, on the stress front, we don't want them to be stressed, but then we also don't want them to be over-sedated. Yeah. And we don't want them to regurgitate, but then sometimes drugs that can potentially help with regurgitation, like omeprazole, they might vomit them. So, there's all sorts of considerations when it comes to, which drugs and the doses, and just, really thinking through these cases on the day. So we are really carefully considering our drug doses and use on the day of the procedure.
Okay.
So just on that as well. So in terms of potentially reducing regurgitation, I will often give a dose of meropenem at a mg per kg intravenously at the time of IV catheter placement.
Okay.
And they have also found that this reduces the isoflurane requirements as well under anaesthesia.
Really?
So that's a second advantage. Yep. If I have the patient in airway surgery, I'm often also putting it on a continuous rate infusion of metoclopramide at a dose of a mg per kg per 24 hours. But typically I wouldn't do that for any of my other procedures.
Why are you more concerned about, not regurgitation, but prokinetics with the airway surgeries versus the others? The reason I ask is I interviewed Dr. Claire Sharp about prokinetics, and she said any brachycephalic in her hospital is getting a prokinetic of some sort. She doesn't care what it's in for, it's going to get it.
It's very much that those are our high-risk patients for recovery. So I really don't want them regurgitating over their brand new airway.
Soft palate.
Wound, yeah. So, yeah, perhaps I'm a little bit more paranoid with those ones, but certainly the others will get meropenem and esomeprazole intravenously.
Okay.
And of course, if I've got a frequent regurgitation, then it's probably been pre-treated as well.
Okay. All right. So that's all pre-med. So now our patient is ready for surgery. Is there anything else pre-surgery, or are we at what? Well, obviously not going to talk about the actual surgical procedures here, but the anesthesia itself. Have you got preferences for these guys?
So we're ready finally to anaesthetize the patient. Or we thought we were, but hold on, there's another step. So one of the things that we absolutely know, and it's so interesting, if you look at virtually any paper and that looks at complications of a procedure, and then you look at what are the risk factors. So, can we predict based on, whatever it is, which patients are potentially at a higher risk for a complication? And virtually all of them, it finds that a longer anaesthetic increases your risk of complications.
Okay.
And so this doesn't mean, rush through the dental. It doesn't mean, sort of try to perform the ovarian hysterectomy in record speed or anything. But I think the key is to just be fully prepared for the procedure. So my nurses have a very long, detailed plan which outlines exactly what equipment I'm going to need, so I'm not waiting for things when the patient's under anaesthesia. So getting really, really fully prepared. And of course, I'm a big checklist fan. So we have pre-induction checklists, which just make sure, do we have everything that we need? Are we performing the procedure that we said we were going to? Is there anything else additional that needs to be performed when the patient's under, et cetera, et cetera? So we're ready. We've got it as good as we can get. And that's one of the things that I often say about brachycephalics. We're not going to be able to potentially get them perfect before anaesthesia, but if we can get them a little bit better and in better shape for the procedure, then that's ideal. We've got a patient that's not stressed. It's been pre-medicated. It's been kept in a quiet space. And then there's one final thing that we're going to do before we induce. What might that be, Hubert? Am I allowed to quiz the...
Yeah. Check that I'm paying attention.
Yeah.
So before induction, what are we going to do to the pre-oxygenate?
Yeah.
Give them oxygen.
Yes. Got it. Yes. So 5 minutes pre-oxygenation, that's really, really important. I mean, potentially for all patients, but especially for these brachycephalic patients, obviously.
Okay. So that's sitting on the table where you're going to knock them out, nice and chilled, nice and sedated, flow by oxygen.
Exactly, flow by oxygen, a mask if they'll tolerate it, yeah.
Okay.
One other thing that I forgot to mention as well when we're placing the IV catheter to help reduce stresses is just using Emla cream as well. Just a simple thing. And most of the time we do that for all of our patients. But again, for your brachy patient, all of those little things can be important.
Okay.
So we're pre-oxygenating for 5 minutes. And the other thing, we're keeping the patient warm. I mean, hypothermia is probably more of an issue intraoperatively and postoperatively, but if we can keep it in a fairly warm space as well, because if it's shivering, then that's going to increase its oxygen requirements. We want to have a good selection of tubes to hand. So, sometimes we can have a difficult intubation, or obviously some of them can have a hypoplastic trachea, so we may not get the tube size that we want into the trachea. And I really don't like any kind of jamming of the tube down the trachea. If I'm feeling resistance, I'd much rather have a smaller tube that's nicely cuffed. So I'll often go, just a little bit on the smaller size so that it's not causing any trauma to the larynx or trachea. Okay. And then we're using induction drugs that have minimal interference with laryngeal function. And I mean, clearly I'm not an anaesthetist, and my typical go-to for these patients is Alfaxan, which I know doesn't interfere with laryngeal function and tends to have a reliable induction that I'm used to using it. So I'm confident with that drug. And I avoid ketamine in one paper, and it was related specifically to airway surgery, but it seemed to be a risk factor for complications. So that's one that I typically don't use at induction anyway, but I would potentially avoid that in a brachycephalic patient. And then in terms of the actual anaesthetic itself, again, not being an anaesthetist, there's no special tips. If anything, I find that while they're under anaesthetic, we've got a good access to their airways, and for most of the procedures that I'm performing, it's not the actual intraoperative period where there's a problem, but obviously, you have all the usual monitoring and contingencies for anaesthetic complications, which is probably another entire talk, with an anaesthetist, but, carefully monitor anaesthesia. And then the next phase that I want to chat about is the recovery. So tell me if I've missed anything up until now. So
no, I think that's great. I just had one question about the premed still. We didn't mention ACP at all. Not a thing anymore in general, or specifically for the bracchies?
Yeah, absolutely. I mean, for the bracchies, it's not my first go-to because it's not reversible. So if they are over-sedated, then I can't take that back. So that's why I tend to prefer medetomidine. And the other reason is because I'm often using small boluses of medetomidine in recovery as well. And again, it's reversible, so I can always kind of alter things as I go along. Okay. There may be instances where that is contraindicated. For example, if there's a comorbidity, if it has severe cardiac disease, etc. But then I'm really calling on my anaesthetist friends.
I'm already very impressed with how much you know about this as a surgeon. I did think beforehand, was this a surgeon topic? Because some surgeons might just go, no, it's nothing special. I just rock up and it's sleeping. Start cutting.
And look, I think that's why we have set up this brachycephalic care unit, because I think we all really try our best to be up to speed, and we work as a team on these cases, so everyone in the hospital kind of knows how we roll with these patients. So, yeah.
Okay, let's wake them up, because this is the part that makes me most nervous when I'm doing anything to a brachy. It's the wake up.
Yeah, so the wake up. So first things first, we want an internal recumbency. We want the head slightly elevated, the neck extended, and the tongue pulled rostrally. And then the next thing that's really important is we want a nurse. I mean, and this would be the situation, I'm sure, for most patients, but we absolutely need that nurse to be cage side and monitoring our SpO2. And often our brachy's, we have flow by oxygen for a few minutes, and then we're just testing to see, are they oxygen and can they manage without the oxygen, etc.
Mm-hmm.
There's absolutely no rush for them to wake up. So we're not trying to rouse them in any way. We want their recovery to be slow and smooth. If they're starting to get anxious and the tube's still in, that's when we might give a little bolus of medetomidine. And these boluses we're giving very low doses, so sort of half a mic, or maybe a mic per kilo. And it's diluted as well so that we can give that accurate amount. So SpO2 monitoring, and one thing I'll just note on this is that we don't want a sort of a set and forget in an oxygen cage. So brachycephalics can overheat quite quickly in an oxygen cage. So we want to be very wary of that. I'd much rather have a nurse sitting with that patient. And, the other thing, of course, is that they can become hypothermic as well. So we're really monitoring their temperature as well during recovery. And right at hand, when they are recovering, you want to have easy access to not only oxygen, but suction. And then we want to have a laryngoscope and an ET tube and some Alfaxan readily at hand as well, because obviously if it suddenly obstructs, the quickest, what you have to do is you have to re-anesthetize that patient. So you need to be absolutely ready to do that. Mm-hmm. And then, a bit more of the same again in terms of really trying to reduce stress levels. So I don't want it to be stressed. I don't want it to be painful. And ideally, I don't want it to be barking at the cage door. So I want it to be nice and calm. And one of the things that we have started to allow, and I do appreciate that, we're lucky in that we do have a little bit of a space for this, but it's not the biggest space. And although we're building another area where it's hopefully going to be a bit more luxurious for owners, at the moment, we do allow them to come and sit cage side with their pet in recovery. Look, cannot emphasize the difference that I have noticed. And it's not just the difference I've noticed, because I certainly do plan on publishing these cases. But over the last sort of 18 months, we've been allowing owners to come and sit with them in recovery after airway surgery. We have a 0% mortality rate. It really seems to make a difference. And I think it's because when we're giving much less in terms of sedation, they are much, much, much less stressed. They're less likely to regurgitate. And I mean, honestly, the complications that I have seen with airway surgery often related to re-obstruction or regurgitation and aspiration. Like those are the ones that are really
so often related to the stress, right? I know that even from emergency, where we're often caring for those patients post-op overnight, and the ones that go south are the stress heads. They sit there stressing and panting, and then you've got that balance between, I've got to drug you to the eyeballs to keep you quiet, or like to the point where I would sometimes send them home. It would sometimes be a few hours after surgery. I actually think you're going to die with me if I don't re-anesthetize you, so just go home. to that
point. Absolutely. And there's that other sort of school of thought, do we send airway patients home on the same day? And I categorically don't, because the risk of them obstructing overnight is extremely low. But I keep them for that 1% that may have a problem. I don't keep them for the 99% that won't. But that's a frightening thought.
I don't want it ever, but you're right. That solution of saying have the owner there, it's better than home.
That's the other alternative. And the owners really, they love it. And actually, it's an interesting thing, because when I first introduced the idea, I found that the nurses were really nervous about the idea. They really were worried about, well, what if there's a complication and the owner's there and I'll feel uncomfortable, or what if they hear us swear, or, whatever it is, they were really nervous about it, to the point that now there's been such a change in their attitudes that they are calling me when the dog's extubated to say, when's the owner coming down? Is the owner here yet? So it's really changed. It was a mindset change, but it's been one that's been really worth it. Also, I won't hesitate to have them out the back if we're performing a minor procedure, be it a nail trim or something like that. Not that we're doing much of that in specialist practice, but if I'm feeling kind, I really like the owners to be present for as much as possible. So, but certainly in recovery, that's been a real game changer for us.
So you said you're going to publish it. Isn't a surgeon said to me the other day, there's actually publication on this, owner-assisted recovery.
Yes, there is.
A massive reduction in complication rates and mortality.
Yeah, so there was a 2023 paper. It's always a little bit difficult about these retrospective papers is that often the cases that have the owners come in recovery are later cases in terms of a time frame, if that makes sense. So you've got a practice that doesn't have the owners in, and then they have a period where the owners are in.
Okay.
And so the criticism of that paper was, well, did they change other things in their protocol that made things better? So, and the same could be said for my retrospective paper. The more evidence, though, that we have, the more confident we're going to feel that it's a real thing and not something that is just maybe just dependent on other things that were happening in that practice. And the other thing is that I'm very wary of people who say that they have a 0% mortality rate, over a period of time, but then aren't happy to sort of share that information on what they do to get that rate. Yeah. So I think that's really important, is to, if you are finding that things are going well, it's probably just as important to publish, well, these are the things that we're doing and these are the things that we think might be contributing to a low complication rate. So
it logically makes so much sense. I mean, and it seems ridiculous that we didn't think of this sooner, because you sit there all night fighting with them and then the owner comes and they calm. So it's just bring the owners in.
Well, exactly. I mean, I certainly used to feel that nervousness as well with the owner about, and were they going to be a pain? And
but what's more of a pain? What's more of a pain? A dog dying on you post-op, or an owner who's a little bit high maintenance?
Yeah, well, that's exactly it. And we've had really good experiences with owners on the whole, and I set them up for the fact that they're going to be in a hospital situation. It can be a little bit confronting. There's other things going on. Sometimes they might be asked to move. Sometimes they might be asked to be quiet or leave or whatever it is, so that there's sort of clear expectations. But we honestly haven't had any issues, and they chat away to the nurses. I mean, we're lucky enough that we have a cage side nurse for these patients, so they're dedicated to the patients. But I mean, it's interesting because, often we'll get the owner to do things like nebulization, and these are just for the airway cases, but often they'll have some nebulization potentially with some adrenaline, and, the patient's much more amenable to the owner doing it than the nurse.
Wow. That's really cool. Really, really useful. Anything I'm happy with that, Abbie. Is there anything we're missing out on? I think that's super comprehensive. For me, the main thing is just these are the good things to think about. It's a shift to say they're not just another dog. They do stress us out. If you do they still stress you out despite the fact that you have such a good plan? Do you still get more nervous when you see you've got a
because I love them now. Like, they're my favorite surgery. Yeah,
surgery, but are they your favorite patients though?
No, they're my favorite patients. I genuinely love them. And somebody actually, one of the ICU nurses over at Underwood said, if you don't love these patients, then don't do a lot with them, because if you're thinking, oh my gosh, I don't want, it's a Frenchie, it's going to be a disaster, then probably you're not the person to be treating that dog.
Awesome. Well, I think they're lucky to have you.
Yes.
Little problem children. I'd love the show notes. I will make some good show notes for this for everybody listening as well, with treatment guides. And again, I'm always nervous of recipes, but at least some guidelines to say, well, here's what we're using. I think that's really cool.
some guidelines. And I'll send you my history template as well
That's really cool.
to share, just so that we can, people can get an idea of the sorts of questions that I'm asking to assess the patient preoperatively.
Amazing. Thank you so much. Before you disappear, I wanted to tell you about my weekly newsletter. I speak to so many interesting people and learn so many new things while making the clinical podcasts. So I thought I'd create a little summary each week of the stuff that stood out for me. We call it the Vetvault 321, and it consists of 3 clinical pearls. These are 3 things that I've taken away from making the clinical podcast episodes. My light bulb moments. 2 other things. These could be quotes, links, movies, books, a podcast highlight, maybe even from my own podcast. Anything that I've come across outside of clinical vetting that I think that you might find interesting. And then 1 thing to think about, which is usually something that I'm pondering this week and that I'd like you to ponder with me. If you'd like to get these in your inbox each week, then follow the newsletter link in the show description wherever you're listening. It's free, and I'd like to think it's useful. Okay, we'll see you next time.